I was so anxious in the months leading up to my first shift.
I remember my first shift, I had trouble figuring out where to go.
My attending asked me, why did I order any labs? I was like a deer in headlights.
If you think about the shoulder, it's relatively unstable. That's the reason why you have such a great range of motion in there, and so it's commonly dislocated. If you ask them to touch the opposite shoulder, they'll be unable to do that because that joint will be stuck. I feel that pop as I go through the ligamentum flavum, so I'm gonna check right now, and you know you're in the subarachnoid space when you start getting CSF dripping out, and that's exactly what it looked like.
It should be CAB, right?
Yep.
So circulation control, hemorrhage control. Scalp lax, you can lose a liter of blood pretty quickly. That's what we're talking about, is massive hemorrhage control. Do that up front and then move on.
Most things there's some diagnostic uncertainty with, and making sure that patients understand that.
Yeah, there's some ST depressions in multiple leads. Nobody's going to blow this patient off. But the ST elevation is just in 1 and AVL.
If you see a problem in AVL, is your habit to immediately go to 1 and see what's going on there?
Absolutely.
Patients on beta blockers, because it blunts tachycardia, and patients who are pregnant are usually excluded from those studies. So you cannot actually use PERC in those two patient populations.
The biggest takeaway with the differential diagnosis of kidney stone is that you need to think of all the things. And if you have a patient who presents and the differential diagnosis includes kidney stone, it better include all these other things as well.